next speaker is Şengül Özdek from Ankara in Turkey, and she will speak about the free flap technique. Thank you very much.
Thank you, Philip, for bringing us together in EVRS Symposium. I will talk about free ILM flap technique for complicated macular hole cases. You know that we have really high success rates in standard primary non-complicated cases, over 90%. With only vitrectomy and ILM peeling, and mostly with gas, sometimes even with air. But however, we have lower success rates in complicated cases, like in persistent macular hole cases, or large holes with atrophic ages, like long-standing and traumatic cases, and in holes associated with pathologic myopia and retinal detachment cases. So this is my first case to share with you. He was a 65-year-old male patient. He had long-standing macular hole, more than 2 years of period, and visual acuity was quite low. And I started with, there was also an epiretinal membrane. You see the negative staining of the ILM there. I started with vitrectomy, ILM peeling and membrane peeling, but ILM was very sticky. I could take only some pieces of ILM, and I tried another technique like hole aspiration under PFCL and massaging of the edges of the macular hole and aspirating the fluid in between, like this with 39 gauge cannula. So this is a technique suggested by Dr. Karabaş from Turkey, my colleague. So when you do that massaging under PFCL and aspirating the fluid in the hole under PFCL, so you see the closure of the hole even during the surgery. This usually helps in such cases, but as you see here, it didn't work for this case. And after resorption of the gas, the hole was still there. So I tried another technique. I should find another technique for this. I did the second surgery with free ILM flap technique. As you see here, I did the same thing as the first surgery in the second one. Did the aspiration and massaging technique again, and I harvested a small ILM from the periphery and put it into the hole under PFCL. It's important to use PFCL in these maneuvers because otherwise you can't manipulate the very tiny free ILM flap. And I could close the macular hole at the end, and you see the evolution of the closure. After first surgery, you see it was opened, but after the second one, the vision also improved in the second surgery, and with long term, again, still we could reach a very good visual acuity level. This was the second case, a young lady with a retinal dystrophy, and she had traumatic macular hole associated total retinal detachment. As you see here, the posterior hyaloid was tightly attached, and I couldn't remove the posterior hyaloid totally. I couldn't reach even to the equatorial area. As you see here, there were some pigmented plaques there. So if I insist, then it will cause retinal break formation. So I could separate to some point and stop there, then started to peel ILM. And since it was a retinal detachment associated macular hole, and also there was RPE atrophy, so I decided to put ILM flap again. For this case, I thought it can increase the success rate. So as you see here, it's easy to manipulate under PFCL. Otherwise, it's almost impossible. I had to do a posterior retinotomy because I couldn't peel the posterior hyaloid till the periphery. Otherwise, otherwise I would prefer to do the internal drainage from the periphery. But you should be insistent on draining the peripheral fluid first before taking the PFCL out. Otherwise, the remaining fluid will cause dislodgement of the ILM flap. And we could again see the closure of this case, which, where the prognosis may be a bit guarded. And you can see that the RP is really damaged because of retinal dystrophy. And this is my third case. She was a very young lady with acute myeloid leukemia, and she had counting finger level vision in the left eye, and her blood level, anemia, thrombocytopenia, general status was really bad, and she had subfoveal and intraretinal hemorrhages at the beginning. That was 5 years ago, and this was the evolution of the case during my follow-up. Because of the general status, we couldn't operate her. As you can see, we could just follow. There was hemorrhage, then lysis of hemorrhage, and it ended up with formation of a retinal macular hole associated with, again, retinal pigment epithelial atrophy. And this was in 2015, 3 years after. You see a large hole associated with a large RPE atrophy area. So there was also an epiretinal membrane. So I decided to do the standard surgery first in those years. I wouldn't do that in these years, but after the first standard surgery, the hole didn't close as I was expecting. Actually, I was afraid of that. And still it was there, no epiretinal membrane, but the macular hole was there. So I had to do another thing. So I planned a free ILM flap technique. As you see, I could achieve closure of the macular hole. And you can see the whole area with this video. And the last case was a very small macular hole with vitreomacular traction, and I was expecting a very good prognosis for this case. I did just a standard vitrectomy, ILM peeling, but the hole did not close. Sometimes it happens. And then I had to do a reoperation with a hinged free flap technique. This makes the manipulation much easier. As you see here, when you relieve one end, you put it into the macular hole area and you relieve the other end so that it doesn't move freely. The manipulations are much easier with this technique, and you have to be insistent on, again, taking the fluid around the PFCL first and then PFCL so that you don't lose the free ILM flap. I don't lie it over the hole but into the hole, as you see here, and you can see that the hole could be closed after surgery. But I think I have made a mistake because I have done many layers. I have put many layers there. I think it's better to put 2 or maybe at most 3 layers of ILM flaps there. So we have done a study with our friends who have adopted the same technique with me, and we have collected our data on just recurrent macular hole cases which were still open after the first standard surgery. We have collected 11 cases, and we could get 90% success rate after this technique for these recurrent cases. And we have published it in Ophthalmic Surgery Lasers very recently. So as a conclusion, autologous ILM grafts may be an option in complicated macular hole cases like failed macular holes associated with retinal detachment, traumatic atrophic large holes, and pathologic myopia associated macular holes. And I would like to again invite you to Florence for EVRS, and also if you can't manage, you may want to come to Mediterranean Retina meeting in October in Sorrento. Thank you.
So, is there any question from the audience? Yes, Ms. Jerry?
Very nice presentation. I am
Thanks.
curious to know, I saw very quickly at the end where you had the table of the number of months that transpired between the first operation and the second. There seemed to be 2 or 3 that were 1 month after the first procedure, but then many that were 6, 7, and 9 months. And the reason I ask is that studies in the monkey have shown that the ILM can regenerate, but it takes 6 months. And we published a series of patients in whom reoperation resulted in terrible vision with paracentral scotomata. And we studied the tissue and found positive staining for neurofilament on the material that was removed at the second operation. And OCTs showed thinning, and we believed that that was an optic atrophy that resulted from retinal damage, and concluded that it was only in the people who were done within a few months after the first operation, and none of the people who were done 6 months or longer after the first operation. So ever since that study, I don't reoperate in less than 6 months, and I'd be curious to know what your impression is, and maybe some other people in the audience.
Actually, I don't have so peculiar, well-formed impressions about this, but what I do is I usually pretend to do it within 3 months mostly, because patients usually do not want to wait too long after, a failure. They usually want to be operated as soon as possible and go on their, social life. But I don't know anything else, but maybe some other colleagues may have some other ideas about that. Because it's difficult, to wait 6 months more for people.
Yes, I understand. But I think that what it really says is we need more data. And if we were able to integrate the amount of time between the first and second operation into our analysis, maybe we would learn something.
Okay, thank you.
Any other question? Yes, please.
Thank you for the lovely presentation. I was wondering what was the visual outcome in your third case, the woman with the leukemia?
Vision did not improve because of the RPE atrophy, but at least the macular hole is closed so that it doesn't become worse. But vision did not improve in that case. I'm trying to show that one. Any other question?
Antonio, yes?
I have a question. Just for the matter of discussion, is there a maximum time, like I have had a hole for 5 years, 10 years, 15 years, that you would not offer surgery to your patients?
Actually, previously, during my first years of vitreoretinal surgery, we were not so willing to do these macular hole cases after 1 year, if we know that it's more than 1 year. But for now, I always try, I give a chance for the case just to try. I don't have any limit for that.
Thank you. And you, Philippe, same?
No, and I would like to ask the same question to the audience. Could I ask you to raise your hand if you operate your patients when there is edema at the margins of the hole? I mean, in my practice, I'm operating patients, not linking my patients with the time of this hole, but I'm operating my patients when there is still some edema in the margins of the hole. And who do the same? Not so much.
I think atrophic ages are
Few, yeah.
Atrophic ages are a poor prognostic finding, but still, I think that was the case in Sophia's presentation. Even if you have, atrophic ages, and that was the case in my third case, with the ILM graft or flap technique, you have a basis for, closure. So that's why in previous years with standard surgery, so we couldn't close those holes. But now with the newer techniques, I think we have chance to close such even atrophic ones.
Okay.
I had an expertise of about 22 cases. The macular hole height was positively correlated with the anatomical and functional outcomes. The
Couldn't-
edema at the edge of the hole, the more the height of the lateral hole edges, the better the prognostic value regardless the closure rate and the functional outcome regardless the delta change in logMAR visual acuity.
Yeah,
I agree
this
with
is
you.
a well-known parameter. Thank you.
But I think we have to be careful in using the term edema because these cystic spaces are actually tractional cysts. Fluorescein angiography does not show significant amounts of leakage to explain the presence of the cysts. So everything is correct, it's just that it's not really edema. It's just cystic spaces resulting from tangential traction.
Completely agree.
Thank you.
Thank you.